endocrine physiology, glucagon, and insulin. All right, so let's start off with glucagon. Glucagon is relatively straightforward. It's made by the alpha cells of the pancreas, and its function is to promote glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. What does that mean? The overall function is just to elevate blood sugar levels. So we want glucose in the blood. So when is glucagon available? When glucose is gone. That's how people remember it. Okay, so if we have glucose gone without the blood, we need glucagon to come in and put more glucose within the bloodstream. Okay, so in patients that are in like the fasting state. Now, we have only receptors for glucagon found in the liver. They're not found in the muscles. Okay, that's a very key concept to understanding glucagon. So glucagon has an increase in hepatic glucose production via glycogenolysis and gluconeogenesis. So that's how we get our glucose levels to be increased. All right, but glucagon increases glucose levels rapidly via glycogenolysis. So the question that they might ask you is, how does glucagon get glucose into the blood rapidly before everything else? Well, glycogenolysis is what occurs first, and then gluconeogenesis and lipolysis and ketogenesis will follow in order to get more glucose into the blood. But remember, glycogenolysis is going to cause the lysis of glycogen in order to have an increased level of glucose in the blood quickly. Once again, it only works in the liver. Okay, it's not going to be found in adipose tissue or muscle or in the renal system. Okay, so glucagon only works in the liver because the receptors are found only in the liver. Lastly, and weirdly, it's used to treat beta blocker overdose. Okay, those are the key concepts of glucagon. We're going to move forward into insulin. Now, insulin's a big one. So let's start off with the structure and synthesis of insulin. So we have pre-proinsulin, then goes to proinsulin, whatever, it gets cleaved. Okay. At the point where proinsulin gets cleaved, it gets cleaved into two things. It gets cleaved into actual active form insulin and C-peptide, all right? And then both insulin and C-peptide are going to be put or placed into secretory granules, and they're going to be released in an equal amount within our body, okay? Very key concept to understanding endogenous production of insulin, because they like to ask you, hey, do you think this patient took insulin by accident, exogenously, or do you think this patient is just having an overproduction of insulin within their body? Well, the answer hides within C-peptide. C-peptide, once again, is a byproduct. It's produced with active form insulin, so active insulin, when we make it within our body, if it's endogenously made, okay? And so that's how you know that insulin is being produced within the body, is if there's the same amount of C-peptide as there is insulin. However, if you have increased levels of insulin without C-peptide levels, then you know that the patient's either taking, insulin shots or they're using medication like insulin in order to either deal with their symptoms or they might have overdosed on insulin, okay? So C-peptide is very key to fully understanding what's going on. Is the insulin being produced inside our bodies or is someone taking insulin as a supplement, all right? So once again, look for the C-peptide levels. All right, number 2, let's talk about actual insulin function. The insulin is going to go and bind its receptors, which is a tyrosine kinase receptor, and it's going to induce glucose uptake, all right? It's going to induce glucose uptake into insulin-dependent tissue, all right? And so insulin-dependent tissue is going to be our muscles and our fats, so adipose tissue and muscle tissue. And that makes sense because that's where we're going to store our glucose. And the whole point of insulin is to take glucose out of the blood and store it for later. And it will store it in those two muscles, into those two locations, the muscle and the fat, all right? And so it also is going to increase glucose uptake into skeletal muscle and adipose tissue, but increases glycogen synthesis and storage. It leads to an overall increase in triglyceride synthesis, sodium retention, and protein synthesis. And most importantly, it's going to lead to an overall increase in cellular uptake of potassium. So patients that take insulin, you have to be worried about their potassium levels because increased levels of insulin will lead to a shift of potassium within the cells, causing a potential hypo decrease kalemia. Okay? So very important to understand that function. All right? So we know the normal function of insulin is to store glucose into the skeletal muscle and into the adipose tissue. But the second function also that's very high yield is to put potassium, accidentally puts potassium into the cells, leading to a hypokalemic state. All right, now we have to talk about the glucose transporters to fully understand insulin. So we have GLUT1. GLUT1 deals with the blood. Okay, that's how I think about it. Okay, GLUT1 deals with the blood. GLUT2 is bidirectional, and this is going to be at the beta islet cells, at the liver, at the kidneys, and the GI tract. GLUT3 is for the brain, and GLUT5 is going to be fructose dependent, and it's going to be seen in spermatocytes. Okay. Lastly, the SGLT1 and 2 receptors, those are sodium glucose cotransporters. They're going to be found in the kidneys and the small intestines as well. So just to remember, all of these is really important. So just commit them to memory. GLUT1 is blood. GLUT2 is going to be like the liver and the kidneys as well as the pancreas. GLUT3 is the brain. And GLUT5 is fructose with spermatocytes. Now you might be wondering, where's GLUT4? Well, GLUT4 is different because GLUT4 is the only one that is insulin-dependent glucose transporter. And the question is, what does that mean? Well, it means it's dependent on the amount of insulin that's within the body. And so why would that make sense? Well, let's think about this for a second. Let's talk about where GLUT4 is going to be found. It's going to be found in the adipose tissue and the striated muscle. Well, since it's found at those two locations, it makes sense for it to be the only one that is insulin-dependent. If there's increased amount of insulin, that means there's increased amount of glucose in the blood that needs to be stored. So if we have a lot of glucose in the blood that needs to be stored, insulin is going to put it through GLUT4 to get it into our adipose tissue and into our striated muscles to be stored. Well, what happens if GLUT4 is not dependent on the levels of insulin and just stays static? Well, then insulin won't be able to transport all of that glucose into our adipose tissue and our striated muscles because we don't have a co-transporter that increases with the level of insulin. So that's the whole entire concept. That's why they say it's insulin dependent. The reason it's insulin dependent, GLUT4 is insulin dependent, is so that at times of high glucose blood sugar, we can actually put them into the adipose tissue and into our striated muscle cells for storage. If it weren't insulin dependent, then there wouldn't be enough receptors in order to get glucose or transporters in order to get glucose into those storage sites. And so we will just have a continuous increase of glucose until we can finally fit everything in. All right, so very key concept to understand that GLUT4 is the only one that's insulin dependent, and it makes sense because it's found at the adipose tissue and striated muscle where insulin is going to store our glucose. All right, now they love to ask about the preference of each organ and what they can use. Well, the brain prefers glucose, so we want to get glucose to the brain as much as possible and in any moment. But it can use the ketone bodies when glucose is not present, right? But that's only during starvation, okay? Also, red blood cells utilize glucose, but that's all they can utilize. So keep in mind those two, that one cell and that organ. So keep in mind that the brain can utilize glucose mainly, but it can get to ketone bodies if it needs to for starvation states. But red blood cells, it doesn't matter. It has to use glucose, okay? It must use glucose. So overall, we've covered now the synthesis with C-peptide, the functionality of insulin with our glucose transporters. Now, the question is, how is it regulated? Well, it's regulated mainly by glucose, right? So if we have increased glucose levels, glucose blood levels, well, perfect. We're going to see a rise in insulin levels because we have to now start storing them. All right, if it's dropped, decreased glucose levels, well, insulin is going to be dropped, okay? We don't need insulin to store our glucose. You're also going to see a rise in insulin response with oral glucose compared to IV glucose due to the fact that we have these things known as GLP, okay, and GIP. And these are incretins. And incretins are just going to increase insulin response, increase insulin production when it senses that we're eating glucose. But we can bypass the production of insulin of incretin production like GLP and GIP by just giving the patient IV glucose. Okay? So keep that in mind. Oral glucose is going to have a much larger insulin spike than IV glucose. Lastly, they like you to know how insulin is produced. Well, first off, glucose is going to come into the pancreas at which transporter? Exactly, GLUT2. So glucose enters the pancreas via GLUT2, and it's going to cause an overall increase in ATP production. The ATP production is going to lead to an opening of the ATP-sensitive potassium channel gates. Okay? Sorry, a closing. So we close the potassium ATP-gated channel. All right? When we close the potassium channel, we lead to an overall depolarization of the cell, and then it leads to calcium entering the cell and causes insulin to be released with C-peptide and secretory granules within the blood. So once again, that process is glucose comes in via GLUT2 into the pancreatic beta islet cells. It's going to lead to an increase in ATP from glucose, and that increase in ATP can be used to close off the potassium channels, which leads to a depolarization of the cell, causes calcium influx, and an overall release of insulin and C-peptide from secretory granules within the blood.